Prepare to start. Okay. I'm going to review a little respiratory first. I have cooked up all three of the Marie PowerPoints. I'll load them. We had them last year, but I'll load them. We did most of the anatomy last time, but this time we'll do the physiology. I'll stick them I'll put them somewhere on the blackboard. You'll see where it is. It's not a big deal. In fact, we do not have to spend a lot of time reviewing the anatomy because the physiology takes place deep in the alveoli. So I'm sure you'll remember the whole idea of this particular system. See, apparently you can't access power. You can't access Blackboard from last term. I have to put them on.
I just didn't realize it was on.
Oh, it's on. It's somewhere on there. Maybe like the third or the fourth. You'll find most of them. Maybe. Pardon me? Did you find them?
Yeah, I think we just have one respiratory PowerPoint from last year.
You have A and B and C are the functional ones. I haven't put those on yet. So and what I didn't because of the change in the textbook. I loaded it differently. Moving on. So you saw this stuff because all of you had anatomy either last term or a year ago last term. So I mean, basically, it's in with the good air, out with the bad. I'm not going to go over all the silly definitions or the anatomy of what belongs where. Well, I want to get to the functionality of it. So without looking too hard at all, you'll see all the structures are there. Everything shakes down here when we start to get into the alveoli area. That's really when things become important. And what we're going to be looking at with all this gizmo is here is to do something called pulmonary function studies. And unfortunately, you guys are healthy. Now, if somebody was like, a chain smoker for 40 years and willing to take the test, which that chain smoker is not, then we might get some abnormalities. What?
So I just, like, right before I came here, I was at the gym exercising. So
good.
Will that affect the results?
Probably make you look even better.
Oh, really?
Yeah. You're stretching your compliance. You're all young and healthy. You should have no problem. I mean, yeah, go out and chain smoke about half a pack of cigarettes. Then we can talk. Well, I'm sure, that was approved for the soccer team. Chain smoking? No, see? Anyway. The best legal home run hitter of all time used to chain smoke in the dugout. A guy named Hank Aaron. It was baseball. I mean, really good wrists. Best wrists in the world. Okay, so we're not going to go through the sinuses and the anatomy of the nose. This is all anatomy, so there's not a lot here. I do want to get down to as I kind of rapidly scroll through this and all the cartilages, and I don't do the voice type of thing. But as we get farther down, now we will start to see what we're looking at. So we're really making the transition between, you might remember there are two zones. From your nose all the way down to what are called the terminal bronchioles is conducting. We rely on pressure changes to allow air to move in and to move out. You probably recall that. Once you get into what's called the respiratory zone, that's where those tiny bronchioles begin to open up into alveoli. Okay, whether they are truly an alveolar duct or just alveoli start to spring from those respiratory bronchioles, at that point, you are so physically close to the cells, to the alveolar cells, that now we are in the so-called respiratory zone, where simple diffusion will take the oxygen and carbon dioxide in their appropriate other directions. Okay? So that's really where all of this is taking place. And really, there's a couple of things that are significant here. One, when we see blockages in the conducting zone, it's going to impair what we're going to be testing today with this equipment called pulmonary function studies. They are typically reserved for people who have respiratory problems, and you're trying to diagnose whether it is an obstructive disorder, meaning it affects the conducting zone, a blockage, or a restrictive disorder, and there it affects the ability for oxygen and carbon dioxide to exchange at the alveolar level. That's what this test is designed to. So anybody of you who are going to be testing it, I'm sure, will test absolutely normal. And in this way, we're going to look at things like vital capacity and forced vital capacity, and something called the FEV1, which is the forced expiratory volume at 1 second. All of these are the standard tests. When do they use them for your age group, for athletes? And this is something they might have used for something like soccer as an endurance sport, or for any other sport, in an effort to try to improve, for endurance, to literally improve your ability in training to not get quote unquote winded. And so this is something that was used extensively in the cycling area to try to optimize breathing, particularly on those long like Tour de France uphill climbs and all that stuff. It's just remarkable what you're expending and how much you have to. I mean, you have to move in and out a lot of air. And they used to train like we have here, with the nose clips on, with this thing sealed in their mouth, and on that exercise bike and different types of pressure, trying to improve their ability to ventilate on an as-need basis. So, I mean, there's a lot of science behind this, and really the way to test it is to really see how it is. And you're right about that, Joey, with regard to exercise. A lot of times what we would do optimally is, it's just too difficult to make it happen here, is if we had an exercise bike and have somebody do it without the exercise bike, then get on the exercise bike and do it, or run up and down stairs a few times. And I mean, and I've seen that done in other institutions. Actually, when I first started doing this without the technology, with an old drum system, that was at IUP. That was a good 20 plus years ago. But the physiology professor there had been there for a long, long time, knew his stuff. They ran a really good lab, but it was all set up. So really, we had a lot of advantages. And so you remember the anatomy, all that type of stuff, branching and branching, 23 orders of branching, etc. So the conducting zone, remember, the rings gradually start to disappear. You get little plates, and finally you get elastic fibers, and then you begin to get more smooth muscle, and eventually the epithelia begins to change as a smooth muscle, and effectively, when the conducting zone ends at the start of the respiratory zone, and that's where the terminal bronchioles, the smallest bi-diameter structures in the conducting zone, give way to the respiratory zone structures called respiratory bronchioles. And you know them because immediately coming off of them, you begin to see alveoli, all the way down to giant alveolar sacs and the millions and millions of alveoli that we have up in most of our lungs volume. And you might recall this particular diagram. So here's a terminal bronchiole here, and now it's fine. When it finally starts to branch into the respiratory bronchioles here, you begin to see the appearance of isolated alveoli. And again, the alveolar cells themselves are a simple squamous epithelia, and you might recall they form sort of a ball-like relationship, sort of like what I always use the analogy, like a puzzle ball, for you puzzle fans. And we're going to have more puzzles for you. We're getting out of the puzzle business for all of you. Unless you want to make me an offer, I can't refuse for puzzles. Puzzled, you're not responding. Perplexed. Partially. Persistently. Shut up, Blue. Nobody freaking cares. And so you remember this, the beauty of this system is they share a basement membrane, the lining cell in the lung, and the lining cell in the both simple squamous epithelia, the lining cell of the alveoli, the lining cell of the pulmonary capillaries. Remember the blood vessels, remember the anatomy, the blood vessels follow each division. And so it allows exchange to occur. And the beauty of the exchange is they don't have the same concentration gradient of partial pressure of gases. What you will come to know in this chapter is the reason they move equally is carbon dioxide is a lot more soluble in the membrane. So it's not all about partial pressures, which effectively represent concentration gradient. It's also about membrane solubility. That's where carbon dioxide moves so equally. We've got alveolar pores. The type 1 cells are the simple squamous. The type 2 make the surfactant. So these are all good things to remember as we approach this unit. The pores play a role. The elastic fibers allow for it to rebound. And again, the beauty of the pores are alternative routes. That's the beauty of this system. And we'll get into it in a little more detail It's got so many safeguards that allow you to ventilate. See, again, and I've said it a bunch of times already, all of a sudden somebody finds out, oh my God, I have to be on oxygen for the rest of my life because finally all of those wonderful backup systems go. And that's typical of the body. We have backup systems that cover us for about 80%. And once we reach that tipping point, now you went from having no obvious chronic disease to having an obvious chronic disease. Obvious in the sense that you have to take steps all the time. And you can see we have constantly those little macrophages sweeping up the debris. They are the cell that you kind of worry about, and we used to worry about a lot more with lung cancer. Here's that diagram with all the orders, all the, I beg your pardon, all the capillaries. You see they're external to all of these structures, be they terminal bronchioles or respiratory bronchioles. You can see the scanning electron micrograph here within a pulmonary capillary. You can see that what I'd like to call the puzzle ball interior. Type 1 cell, the macrophages in blue, the type 2 cells in green, all the other cells being, again, simple squamous. And what does that mean? Surface area, surface area, surface area. Yes, sir.
These cells are the small cells referred to, like small cell lung cancer.
Those macrophages.
Okay.
It's those. That's the so they call it either small cell or oat cell because they kind of look like oats. When they would take out one of those tumors, pretty ugly. Pretty ugly. Not a diagnosis you want to have. That's still a very bad. Lung cancer is never a good diagnosis. Okay, and so all of those are part of it. So as you begin to look in here, again, it's about. If I go backwards, you might remember me talking about this when we did the anatomy. Back here, I mean, where you see that darkened area, that tells you that you're using. This is really where the bronchiole is because you still have enough connective tissue and maybe some smooth muscle, which clearly, so these are the openings, and you hear all the alveoli kind of coming over it. And what happens when someone has emphysema, these get destroyed. Some of them get thickened, some get destroyed, and what happens is the air it becomes trapped, and that's what emphysema means, trapped air. It's not exclusive, as you know, to the lung. We can add emphysema anywhere, almost anywhere. So subcutaneous emphysema would be a highlight of gas gangrene. Or necrotizing fasciitis, the so-called flesh-eating bacteria. So here's the respiratory membrane, the single layer of the type 1 cells, etc. The type 2 cells play a role in allowing it to open and close. They have antimicrobial proteins, all good. Here's the alveolar pores we talked about before. And now this, and I'm not going to go into the lungs and the base and the fissure and who cares. Any of that type of stuff, or the number of segments or the lobules. That's all anatomy. We're not doing it, or the blood supply. We're not doing it, or the innervation. We're not doing it, or the linings. We're not doing it. Any of that stuff. So that's there, and that really just. So I wanted to briefly introduce you to that first one, and so I'll get you the other ones. Just to reacquaint you with the anatomy in 10 minutes worth of me blabbing. Unless you haven't had enough of me blabbing to last a lifetime. Imagine being my wife and coming home and listening to me blabbing the whole time. Let me just see the darn thing, would you? I hate when it does that. So now we are endeavor. Here's our area of endeavor, and that is respiratory physiology. So more than just why it's so important for in with the good air and out with the bad, how it all kind of works. So in with the good air and out with the bad. And this is, if you are interested in this from a technical standpoint, that guy. With its pressures, this is not Stein's material, this is the Buxton material. So effectively, to summarize, there is a negative pressure in your lungs, a suction pressure, which is tiny. If we think of 1 atmosphere at 760 millimeters of mercury, maybe the lungs are 755. So the beauty of that is because there's a negative pressure, air goes into the lungs and keeps them to some extent inflated. The problem with that is that the benefit of that is it doesn't allow the lungs to collapse. They're like a balloon. And if they collapse, even with the presence of surfactant, cells begin to adhere. and you need to reinflate lungs. That's one of the things we worry about for years before they, even with airbags, before airbags, being hit by the steering wheel, trauma, blunt trauma here would rupture the pleura and a lung would collapse. You had to reinflate it. I mean, I can't tell you how excited residents were. Whew, we got a collapsed lung, because they could pass a thing called a chest tube, suck the air out of the pleural cavity, seal it, sew it over, and and eventually let the pleura. I mean, it was just, oh, I'm doing it because you do that in the emergency room. It's like, oh, residents get all excited. Any of you going in that direction? Oh, we get to do that. We get to, you get to do procedures in ER or all that, or in the outpatient clinic. Everybody gets kind of excited. So, I mean, so it's effectively, that's the nature, without going into all these different pressures. To me, that's not. So usually always about 4 millimeters of mercury less, okay, as you can see. So there's always, so the atmospheric pressure, fluid levels must be kept at a minimum. Excessive fluid is pumped out by the lymphatics. If fluid accumulates, potentially that could collapse the lungs. That's one of the problems with infection. That's one particularly infection that might affect the lymphatic structure. So there's lots of things to worry about that are there. So two inward forces promote lung collapse. The natural tendency for the lung, the elasticity to recoil. Okay, surface tension of the alveolar fluid also plays a role. So, but surface tension is useful in both directions. It allows it to expand, it allows it to collapse. Okay. And so what happens is that surface tension of the fluid, remember the lining fluid of the pleura, the parietal pleura on the wall, and the visceral pleura on the lung, basically there's the pleural fluid adhere to one another. So when you and I, when we breathe, when we expand our chest and lower our diaphragm, that expansion of the chest and the vertebrae are effectively, we're assisting that lung in increasing it. It's all, everything here is about one thing. My favorite chemistry expression. No class this Wednesday, exam next week. That's not me. That must be Dr. Soda. Here it is. My favorite, and your favorite too. Good old ideal gas law. So what happens is, because it's a closed space, as we increase the volume, we lower the pressure in with the good air, and as we reverse it, out with the bad air. So all these laws, Boyle's law and whatever others law, they're all basically variations of the ideal gas law. So I don't go crazy in having to memorize them. You can all derive them because we look at, when the lungs are inflated or when the lungs are deflated. And that's like the P1 and versus P1 and V1 and P2 and V2. They're going to equal out. And so what happens, all the ideal gas law means that we assume that, our air is behaving ideally, though it doesn't really do that. See, that's what you get when you're a chemistry major. So you don't know what you're missing. Remember, I would say BLTC, better living through chemistry. BLTOT, bacon, lettuce, and tomato on toast. MLT, mutton, lettuce, and tomato, where the mutton is sliced very lean. Princess Bride. Have fun storming the castle. So old. I mean, we were laughing about it. Dr. Badger was going, he said, telling my students, all we had to do was bring the Fonz and he could do this and fix all the machinery. And none of his new students knew who the Fonz was. You know who the Fonz was? From a vintage show in the 70s called Happy Days. And Dr. Maurer hit it spot on when he was talking about, I walked in and saw Dr. Badger fixing Dr. Maurer's refrigerator. And I said, "What's up, Matt?" And he goes, "Oh, I had MacGyver come in for a fix." I mean, that's Dr. Badger, MacGyver. I mean, he could probably give him a toothpick and a couple of rubber bands. I'm sure he could fix anything. for the great, a great show for the great Richard Dean Anderson. Just brilliant, brilliant. I love that. Okay, so that's part of it, and they give you all the pressures, and I don't care about any of that stuff. It's there. So a name for a collapsed lung, atelectasis. Okay, plugged bronchioles will do it. So pneumonia would be, of course, that could cause your endogenously, not from external trauma. The ones where we see it from the accident or sharp force trauma, like a gunshot or a stab wound, is called a pneumothorax. So it just means pneumo, effectively being a hole or air in that cavity, can occur from either a wound or a rupture of the pleura. And again, you have to use chest tubes. And then as the pleura heals, then you can gradually, we call it advancing the tube, pulling it out and letting it, and it will heal by itself. That's the only thing with putting in chest tubes, you had to look. I'm sure it's different today. You had to we go send them over to X-ray to make sure you're having the right place and blah blah blah, that type of stuff. And so we know ventilation, inspiration, expiration is about mechanical changes. Volume changes lead to pressure changes. Pressure changes lead to the flow of gases to equalize the pressure. Here we go with the ideal gas law, Boyle's law. Okay. Pressure and volume. Gas always fills the container they're in. If the amount of gas is the same as the container size, reduced, pressure will increase. So again, they vary mathematically. We knew this inversely on a constant basis, depending on the ambient temperature. The N, the number of moles, remember that? See, ideal gas law, love that. It's funny, when I took the MCAT, that's basically all you really had to know. You didn't have to, they didn't have molecular biology. Hard to believe. That's why a chemistry geek like me could do so well. There's a lot of math and chemistry. Jeez. So inspiration. What causes us to breathe in? Principally are the diaphragm and the actions of the intercostals, the external intercostals. The only part about breathing that it requires energy expenditure is regular inhaling. We don't even notice it. We just inhale. So that action or that active process, we're flattening the diaphragm, we're expanding the chest cavity. And like I said, that's going to increase the volume. We're going to flatten it, increasing the volume sort of north-south. And then east-west, you're going to the external intercostals. When you use the internal intercostals is when you take the proverbial deep breath. And the same way, we might use abdominal muscles or use additional force when we're going to blow out the candles. And you're going to see that this is something that we're going to be doing here with the test that we're going to be doing. So those actions will effectively increase the thoracic volume. They'll lower the pressure, and you can get a breath. And so they go through a whole series of things. I can't read this from here. I can't read it on my screen. I mean, I'm sorry. I have to get like magnifying glasses on me. So as you can see, when we inspire, the volume increases, the lungs are stretched, blah, 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 blah. It's not a whole lot, 1 millimeter of mercury, but it's enough, okay? So during the same period, it lowers it about 6 millimeters of mercury all told. So what we're going to be doing is forced deep inspirations. You're going to take your deepest breath. Who's ever testing, so we'll need one gal and maybe one guy, or maybe, sure, I'm poor Kenzie. I love her to death. You're a good sport. Yeah, you're a good sport. You just are. I can tease you, comparatively speaking. You too. You know that. Forced deep in can occur during vigorous exercise or in people with chronic obstructive pulmonary disease. That's part of the problem. Understand that, I mean, it's not one thing to be exercising vigorously, and that, Joey, is kind of where you would have actually been able to see an increase over what your normal was. And this is what we would test. Like, if you get somebody right after they get off the treadmill, and all of a sudden, and they take a few seconds, then take it, you might even see it increased to some extent, so you can get closer to max. And a lot, but what happens in people with, see, breathing is normal and effortless. You and I don't think about breathing. You were like me, insane smoke for all those years. Believe me, sometimes you were thinking about breathing. Okay? But normally you and I, you don't get breathing a second thought. You don't even know you're doing it unless somebody says, check your rate of respiration. And all of a sudden you forget about it after you don't think about inhaling it. It's effortless. You expend a little bit of energy per force because that's where, and everything else is elasticity and rebound that goes on there. When people have any chronic respiratory disease, whether it's COPD, then they have to use other muscles. They're using neck muscles, pectoralis muscles, sternocleidomastoid. They're using all of those muscles to augment that effort. That fatigues you. Breathing shouldn't make you tired. Normal processes should make. It's the same thing with walking. When somebody injured, we've all sprained an ankle or hurt your foot or heck stubbed your toe. You walk differently. You fatigue more because your walking should normally be effortless. So there's all sorts of muscles that are involved. Okay. I mean, so you can look at those types of things. So we look at these, and expiration is normally a passive process, no external energy. Inspiratory muscles relax. So we're just reversing the process, the elasticity. The diaphragm goes back to normal. You're effectively, the volume of your chest returns to normal, etc. If we're blowing out the candles, okay, forced expiration is an active process, and now we bring in our abdominal muscles, intercostal muscles. I mean, it's the same thing as like if you're straining to go to the bathroom, if you're straining to lift something, that's when you begin to use this forced process. What I do when I have to try to, it's awful. We have to have like a step ladder to get to anything anymore, my wife and I. Just shrinking. My stepson, who used to teach here, is like 6'2" or 6'3". This is much easier. You just reach up and get it. It's awful. And more of these stupid things I can't read. And so this basically is showing you the changes that occur. And this is something we're going to look at. Not so much up here, intrapleural, intrapulmonary. We're going to look at the volume. The typical breath that you're not even thinking about is about a half of a liter. We have a fancy name for it. It's called the tidal, Tidal, volume. Tide in with a tide, out with a tide. Tidal volume, and it's about a half a liter, or a good old 500 milliliters, whatever you want to think about it. And you don't even think about it. So during each breath, the pressure gradients move about a half a liter of air in and out of the lungs. You don't think about it. We have to figure that when we start to look at these pulmonary function studies. So a lot of processes move air in and out of the lungs beside breathing. Okay. Things like that we don't really think about, but there is some movement: coughing, sneezing, crying, laughing, hiccups, yawning. I'm familiar with yawning because I see most of you doing it when I'm talking.
How much laughing?
No, never. Thanks.
We need a laugh track. There needs to be a laugh track.
We have an expression for that in Yiddish called kishmir and tuchas, which I won't explain to you what it means, but I think you can derive the meaning. Since you're telling nowadays, they were talking about banning the proverbial tush push. The kishmir could be pretty obvious. You don't listen, Olivia, because you're a delicate flower. And Maggie's a hockey player, so she's very familiar with this language. I mean, our basketball coach, wonderful. He did a great job. He's been a great coach for a long time. I walked in on one of these spring practices. Oh my God. He had some very simple declarative statements to the players who didn't look like they were working. It was like, oh my goodness. You're in that old gym. Whoa. My son's a sailor. I've heard some swearing. But I believe coaches do that. That's why the parents didn't like me coaching the soccer kids, the little 6-year-olds. You get your... I didn't say that to the children a lot. So the factors that influence... See, those were... You had so many opportunities to smile there, didn't you? Yeah, not much. Lauren's looking at me going, no, that wasn't great. The three physical factors influence the ease of air passage and the amount of energy required for ventilation: resistance, surface tension, compliance of the lungs. The lungs are just like it's like a couple of balloons. They're stretchy. As you get older, they get less stretchy. Trust me, they do. Surface tension. So you have to be making a amount of surfactant. Is there anything blocking the way? And it could be just as much as you and I having a cough because something was blocking the way, mucus, something, anything could have done that type of thing. And then you can do this guy over there. You want any of this stuff, he will handle it. So resistance is usually insignificant. The diameter of the airways are huge, bronchi. And as you get down the progressive branching, but we don't look at it. I know those bronchioles are effectively, they're microscopic. You can't see them, but we look at total cross-sectional area. So any resistance usually occurs in the medium. So when we have blockages that really get to us, or when we would have a tumor, as those bronchi begin to go from being distinctly wide until they're starting to approach microscopic. That's when we sort of make the transition to bronchioles. We use that OLES when they get to the point where just about where you can barely see them. So resistance disappears at the terminal bronchioles because at that point diffusion takes over. So it's an interesting chart. Here's where you can see where they peak at. Those medium-sized bronchi are starting to get smaller and smaller, where resistance and blockages become an issue. And then, as assuming the air gets through, then the resistance is almost inconsequential, and it becomes that. Now with diffusion taking over, it doesn't matter. Okay. Breathing will become more strenuous, as you might, severe constriction, life-sustaining ventilation. And so that's the distinction between someone has a blockage here. Someone was struck in the throat by a projectile. Someone was at an auto accident and it's being here. They had thyroid surgery. So then that's when you utilize a tracheotomy tube, or tracheostomy is the appropriate term. And using that because there the air just can't get in where it's supposed to. Once you're down to those bronchioles, that doesn't help you. Okay, when your bronchioles go into spasm, like in an acute asthma attack, or if you're talking about somebody with an anaphylactic episode, that's a very significant issue. Now you have to take extraordinary steps. That's where the EpiPens and things like that come in. Thank goodness we have those today. They've been a game changer. It's like anything else with medicines. It's where they overcharge for those things. They should. It's just. I know. Must be high school. They're throwing off the lab recruiting. We did one of those Tuesday. Olivia was part of it. We were recruiting issue, trying to get some prospective pre-meds in. And she was excellent. Yeah, you were very good. And Taya is just brilliant for our MCAT class. Oh my God, she was great at that. Oh God, what a star. Nevertheless, all things aside, we really, I understand pharmaceutical industry has got research and development is extraordinarily costly, and launching these things, but there's a fine line. When something that could be life-saving. That's just me editorializing, as I'm prone to do. Surface tension. Okay. And so all of this, so effectively, the surface tension plays a role. It can induce it to collapse. The surfactant really plays a significant role, preventing the alveoli to collapse. So as long as the type 2 cells are functioning properly. And yeah, they could form cancers as well. They're just not as common. The most common cancers are the type 1 cells. That's when you see the typical, not that anybody would want to have that diagnosis. And I am very, 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 very fortunate. And I'll say it again. I said it before last term. My long history of smoking has permanently elevated my risk of lung cancer. There's a 5 out of 6 chance, roughly 85% chance, if they would find a quote spot on my lung on a routine chest x-ray, it's cancerous. My mom went through that scariness. Fortunately, it turned out to be some scar tissue, probably from a subclinical pneumonia. Calcium, because they were just about ready to take out the lung. The surgeon up at Strong Memorial in Rochester, thank God, was on his game. Very experienced, and it would have been awful. So Infant respiratory distress syndrome, that's the famous one that we have associated with surfactant. Now that we can make the surfactant, things have changed. But really, as you can see, fetal lungs do not produce adequate amounts until at least the last 2 months of development. So it used to be babies under 26 weeks. Now we can even have life sustaining at 24 weeks. It's been a game changer for all of those things, very much so. My middle one is born about 5 weeks premature. Thankfully, did not have a lot of respiratory problems. There, for those of you who are not acquainted, they treated him as though he was going to have respiratory problems. Both my younger two, my daughter and my younger son, were both born of polyaddicted birth moms, so they inherently were special needs kids. There's stuff we had to be very wary of. There was a large element of risks involved with it. So, and they know I share that with you folks. It's just to give you an idea that there's challenges everywhere. So, natural or synthetic surfactant has played a big role. Again, mechanical ventilation that can lead to pulmonary dysplasia, so it doesn't grow properly. And now compliance. Okay, how stretchy? Distensibility. Higher lung compliance. It's that balloon that you can stretch. Just the way before we blow it up, we would stretch it out in the old days. I don't know what they do today. So that occur, measure how stretchy they are, easier to expand. Here's the stuff. So compliance would be diminished by non-elastic scar tissue, reduced surfactant, decreased flexibility in the thoracic cage. The trouble is, remember, we go back to the anatomy, we're dealing with costal cartilages. Cartilage has a certain amount of give. There's a certain amount of give that's associated with where the ribs attach to the thoracic spine. You've got those, what they call demifacets, one on the vertebral body, one on the transverse process. I know it's a long time ago. Those things, they're just not as good. I could see, I saw it so vividly with what was going on with my mother-in-law. She was very, very close. You could see what was happening. It's very, very, very sad. So all of these types of things, tuberculosis, fibrosis, blah, 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 anything can lower the lung for compliance. Certainly any of these, here's some of the other ones I don't like to mention, common in old age.
How old are you?
Too old. When's our final, your final, our final here is the 6th, right? The Saturday of that week is the 10th. That's my birthday. I will be 74 years old. I don't look a day over 73. But I'm going to be a great grandfather. Not that funny. She's looking for I don't like the boyfriend. Maybe you'd be interested. Interested family, but she's very pretty. What are you laughing about? Just saying. Hey, she's close enough in age. I could recruit. The one thing she doesn't have in common with any of you guys is school. This is not her happy place. Back so soon? Were you given the tour?
No, I had a question and it needed to be answered immediately because he was late.
What?
I had a question for Patrick.
Oh, for him?
I needed him before he leaves.
Oh, guys.
You know how that goes.
Believe me. So, this is what we're doing today. After all this, my blabbing for these last 40 minutes, this is what we're going to do. Well, we're not going to get into physiology. We're just going to test these things. So when you hear the term vital capacity, we can estimate roughly your total lung capacity. You can go online and, age, height, weight, measurements, about your chest here and here, several areas, and pre-existing conditions. And you get a pretty good idea of what we call your total lung capacity is. Okay? So we have several volumes, okay? You just heard about one called tidal volume. The typical in and out, roughly a half a liter. So we can combine those volumes and they are able to make what are called capacities. So there's several respiratory volumes. Any two or more together make a capacity. We're going to look at the most important of them, vital capacity, the actual space that you have available to do exchange. And we're going to do it in such a way that we're going to maximize it. It's called FVC for forced vital capacity. So think of that as your biggest inhale and your biggest exhale to follow it and blowing it out as fast as you can. And we look at the peak and the trough and we figure out what it is using the technology and sort of have an idea of what it is. I've had some big numbers when we used to use the old water-based, like a basin was in the old lab. They put it away, because I ordered it years ago with Dr. Dresser's charge, because that's the way the old systems used to work. And I had a guy who was just a real workout freak, big, strong kid. He was a nursing student, good 20 years ago. But it was the same gym my daughter did over in the Harbor. And it was like, his capacity was about 6 liters, 6.5 liters. Even on that, it was remarkable. So respiratory volumes and capacities are usually abnormal in people, and not that you should have it. And so what effectively this is a spirometer. So to make sure I don't infect anybody, these are sterile inside. The only thing you have to do, Kinsey, when we do this is we have to just measure how it flows in and out of your mouth. So yes, you get to wear.
Wow, that's cute.
I'll order extra, you can take it home.
Okay.
Sure.
So how would things like stress affect being able to take like your biggest breath? Because sometimes I feel like whenever I'm more stressed, I can't fill my lungs.
I'm sure you. It's just that sometimes stress preoccupies a lot of things. It's hard to measure what stress is. I mean, I could, but for my wife, which had such an impact, the stress that she went through as her mom, even though 98.5 years old, it's a good run. But you can see the toll it takes on you. Physically, you become short-tempered, you might forget something, you might be aggravated, and I certainly induce that. No, but I'm saying, in relationships, you see, and physically stress takes you up because you're more likely to get sick. So your immune system responds. I don't have an answer for it, but stress, that's nothing I haven't heard before from folks. So the spirometer today, now we use electronic measuring devices. This is this. So what we're going to effectively do without having to touch it is we're going to take this sterile cylinder, put it in whichever size one of these fits in. It only fits in one. Stick it in one of these. Basically, seal your around that. Seal your mouth around it, and basically do some practice breathing, and then take your biggest inhale and blow it out as fast as you can. Because the system is sort of awkward, I'm not expecting to get negative numbers. Okay. So that's the device, and that would be the device they'd be using today in a physiology lab where you were getting treatment. So the tidal volume in and out with each breath averages about half a liter. Your inspiratory, it's much easier, you have a much greater reserve in than you do out consistently, because our tidal volume hardly uses that much of our lung space. We have a lot we can bring in. So where the expiratory reserve volume is probably half as large, meaning our ability to blow it out, not nearly as much. And so there's always going to be residual volume. There's always some, and it's a poor term, but it's a common term. It's called dead space. So the residual volume, we have to have a certain amount of the lungs in the tubing. We have a certain amount of the lung in the lungs that maintains the fact that there's air keeping things inflated. And that's something we estimate. So by estimating the total lung capacity and then using this technology to try to find the vital capacity, adjusting for the fact that its equipment is not 100% reliable like they're doing in the lab, you can get an idea what the total lung capacity is. And in general, and it's not a hard and steady rule. It obviously depends on size. Men obviously physically a little bit more than women. So if you have a man who's a little more diminutive versus a gal who's a little bit bigger, more muscular, maybe they'll be very, very similar. I mean, there aren't that many differences, but it's not a hard and steady rule, but I think you get the idea. So we look at all these, and the one we're looking at is vital capacity. So we're going to take that big in and we're going to force it. And then that'll encompass the tidal volume. As we blow it out, we'll have the expiratory capacity, and that'll give us the vital capacity. And from that, you can kind of deduce, because on average, it's probably that's about 80% of your total lung volume, and you can just do the math and get the other 20% will be your vital. And again, you can check that, and if anything, you can sort of extrapolate that if you actually looked at one of those tables and kind of had a pretty good idea of what your total lung capacity should be, and then you could adjust your vital capacity accordingly. So I'm saying this is not 100% reliable. It's just fun to do. And so this is what it looks like. So they're using a 6-liter model, where the residual volume is around a liter. So that includes both anatomical and functional dead space. Anatomical has to be there. Functional is the thing that adds up over time. If you're a smoker, if you've had respiratory problems, anything along those lines, if you've had injuries, if you had previous pneumonia or some type of lung ailment, a really bad case of influenza, all of that takes its toll. Not enough to be significant. Okay, comparatively speaking, here's the tidal volume, the back and forth number here. And here you can see that big reserve inspiratory, blowing it all out, expiratory. And if we look from the peak to the trough, or the trough to the peak, either way you want to look at it, you're going to get the vital capacity. That's what we look at. Almost done with this presentation. This chart just names the volumes, gives you some ideas in the average male and the average female. And you can see the way they're looking at the numbers, total lung. So that's a difference of about 70% based on what the numbers here, multiplied by 0.7, you get, that's right. Is that about right? I know, I've got a barrel chest. And that's part of the reason why I was allergic to this. You might remember me telling you that as a heavy smoker when I was a resident, and they did a routine chest x-ray because we all had to have them. And the radiologist calls me in, and he was, man, in his 60s, brilliant, well known in Philadelphia. He said, Lou, I know you're a smoker. He says, you got to stop, because if you don't, you've got the perfect chest for emphysema. I've got that barrel chest, and that's, the physical plays a role in that. That was there. And as intelligent man as I am, as you all know, it only took me another 30 years to quit. Quitting is easy. Staying quit. Only took me 30 years.
You said you had a perfect chest. Yeah.
Please. You're making me blush. I have a body by Pillsbury. The doughboy. I think that's funny. The people in the back were sleeping. You got that. Maddie got it. Sydney got it. Everybody else ignored me. So does not contribute to gas exchange. So of that tidal volume, we know there's at least 150 milliliters on average that is useless. So every time you inhale and exhale, you're only getting in of useful oxygen and carbon dioxide exchange about 350 milliliters. So that's the anatomical. We have alveolar dead space because any variety of things. So we have a total dead space that to some extent is estimated. I'm going to flip through this and just show you why that's so important. This table. And this is something you tell people, whether it's a patient or whether it's somebody in your orbit who's having a problem. Normally, we can generate 10 liters a minute. And again, that's a little bit more than most of us. The minute volume is something that we want to equal to our cardiac output, which is closer to 6 liters. But for argument's sake, and the numbers, they basically said if you were breathing relatively rapidly at 20 per minute, you would generate about 70% efficiency. So what happens when somebody's hyperventilating? They're breathing so rapidly, even if they double that to get the total minute volume, effectively they're only 40% efficient. So when someone's, what do you tell somebody to catch their breath or to calm down? Tell them to take slow, deep breaths. You're much better off increasing the volume and lowering the rate to get to that same number, and you've increased the efficiency to 85%. That's the idea. And so a lot of times people, when they get excited, stress situations, see an accident, something terrible happen, you get that. So what's this all about? Why are we doing the test? There are two types of diseases, and sometimes they overlap, to be fair. Obstructive and restrictive. Obstructive means blockage. Something is reason, typically bronchitis. Chronic bronchitis can be asthmatic in origin. It can be a tumor. Tumors frequently occur in the bronchi. Not unusual there. So, where total lung capacity, forced respiratory capacity, and respiratory volume may increase because of hyperinflation of lungs. So what we see with somebody with this is they're trying, they can't get it in, so they're late, and they're like, what happens is the air gets trapped inside. And again, they can get emphysema covers both. Emphysema can become from obstructive and can overlap obstructive and restrictive. How do we separate the two? We use something called a forced expiratory volume. If there's an obstruction, it would prevent you from taking that deepest breath, your forced vital capacity. You should be able to expel 80% of that in a second. We call it the FEV, forced expiratory volume, in 1 second. Restrictive reduces your total lung capacity. Tuberculosis is very, very destructive. Exposure to environmental agents. So they all decline. The lung can't expand for any of a number of reasons. It loses compliance. There's damage all over the place. And so what happens, that number, that actual vital capacity number is less than it should be. And again, we have an idea what it should be based on things. So this is how we test those. We do these pulmonary function studies. So the forced vital capacity, as I'm telling you, and the forced expiratory volume. The FEV1 is the amount of air expelled in a second. Healthy individuals, 80%. So all we're really interested in what your forced vital capacity is and how rapidly you can expel it. And that's what we can see from this. Obstructive diseases exhale less than 80% in the first second, whereas restrictive can exhale 80% or even more. Okay? It's a little bit different because they're really, the air's hardly being used. And almost you can bring it in and it could go right back out if you want to think of it that way. And so that's when we look at the minute ventilation or the minute volume, roughly 6 liters a minute on average. With exercise, it can increase dramatically. And that's one of the things that is kind of neat to do when we could incorporate it at the gym. It was easier. I did it with the old machine and carried the darn thing down, or drove it and carried it when they had the fitness center was where, whatever that building is, where the veterans are. That that used to be our that used to be the old gym where they built the complex, and that's that whole thing with the alveolar ventilation rate. And we'll stop with that now. So let us experiment. Let me do this. Exited. I've stopped.